This is Chapter 54, Care of the Patients with Esophageal Problems. I have you a nice little picture here of the fluid in the stomach and how you can already see that the stomach contents are regurgitating back up through your lower esophageal sphincter, back up through your esophagus. So GERD is the most common upper GI disorder in the United States. It can affect any disease process or any age. It occurs because of a backward flow or regurgitation of stomach contents into your esophagus. This arises from continuous and persistent gastroesophageal reflux. Reflux symptoms chronically and continuously expose the mucosa in the esophagus to gastric acid, and that results in inflammation. A person with acute symptoms of inflammation is just considered to have mild or severe reflux esophagitis. It affects more your middle-aged and your older adults. Upper esophageal sphincter is also known as your cardiac sphincter. And normally it prevents backflow of contents into the esophagus. It's at the upper part of your stomach. It stays contracted at rest to prevent that reflux. Your lower esophageal sphincter is located more near your stomach. Your pressure is higher here, and this particular sphincter, it sits down there, but it's supported by the angle of His that is formed as the esophagus enters the stomach. So it's kind of freestanding, but the angle of His helps support it. This is called your pyloric valve. And realize that you have a certain amount of pressure in your sphincters, in your stomach areas, and anytime that pressure gets higher than what it's supposed to be, say if you've had a trauma in that specific area, then it affects those sphincters. The most common cause of GERD is the excessive relaxation of the lower esophageal sphincter. So it's normally contracted, but anytime it has extra pressure on it, then it slowly starts to become relaxed, and then you'll get the regurgitation that allows, again, those gastric contents to flow into the esophagus and exposing the esophageal mucosa to the acid. People that are obese and overweight are at highest risk. Increased rate produces, again, increased abdominal pressure. Nighttime reflux is worse on the esophagus due to prolonged exposure to the mucosa. The patients are in a supine position so that acid sits there a lot longer than it would as if it was in the daytime. So what are we going to be looking for with GERD? A previous history of heartburn, atypical chest pain, asthma. New onset asthma can be a risk factor, morning hoarseness, and of course dyspepsia, which is just indigestion. All these symptoms are an indication of acid reaching the esophagus. Regurgitation, eructation, which is belching. People who have a lot of belching are at risk for GERD, flatulence, or gas. Dysphagia, and then odonophagia, which is painful swallowing. Regurgitation puts patients at a risk for aspiration because the regurgitation occurs a lot of times when the patients are lying down, and they can also notice a sour or bitter taste. Regurgitation and dyspepsia are the main symptoms of GERD. Indigestion symptoms include abdominal discomfort, feeling full, nausea, burping, and realize too that symptoms can occur and can mimic a heart attack, and these patients can feel just like they're having a heart attack when it's just indigestion or GERD. So it's really important for the healthcare professionals to determine with a good assessment process and history as to far as which disease process it is. These symptoms are also worse when the patient bends over, strains, or lies down. So how are we going to treat GERD. Antacids, PPIs, your proton pump inhibitors, and histamine blockers. The purpose of treatment for GERD is to relieve those symptoms that treat esophagitis and prevent complications. A couple of complications that can occur are strictures. Strictures are narrowing of the esophagus, so the esophagus doesn't have as much room for the food to go down. Barrett's esophagus is another complication. It results from excessive exposure to the acid and pepsid. Barrett's esophagus is where when that tissue is healing, the tissue can actually have changes. You have a normal squamous cell down your esophagus and through your stomach. Well, this squamous cell can change to a columnar, a more elongated epithelium. And this new tissue, it's stronger, more resistant to the acid, so it helps to support the esophageal healing, but it's also considered pre-malignant and is associated with an increased risk for cancer in patients. It's called Barrett's esophagus. In countries with foods that are higher in nitrates, those that are pickled or fermented, Barrett's esophagus is linked to esophageal cancer. A pH study looks at the acid in your stomach. A physician will go in and put a very small tube, almost like an NG tube, down into the upper portion of the cardiac sphincter. The pH in your distal esophagus is basically neutral from about 6 to 7. The pH in your stomach, in the top part of your stomach, is normally about 1.5 to 2. You can have some minor capillary bleeding. This does happen often, but hemorrhage is rare. So when they look at this pH study, it can actually tell them what the pH in your stomach or close to your stomach is, and if it's on a higher end, then it can be seen as a way for patients to have surgery. There are several surgeries that can go in there and help get rid of that specific acid, but most physicians will try medication first. So antacids increase the pH level of your gastric contents so they're not as acidic. It also helps to deactivate the pepsin. Now, this is not helpful in controlling frequent symptoms. Antacids are for very short term, things like Maalox, Mylanta. PPIs, proton pump inhibitors, shut down those proton pump inhibitors, and this helps to decrease the acid secretion, so it decreases how much that acid is actually secreting in there. It is the main treatment for GERD. Protonics, Prilosec, Nexium are a couple. It is meant for longer term use, but for over years, it can cause community-acquired pneumonia and GI infections such as C. diff. It can also increase the risk for hip fractures, especially in older adults. PPIs interfere with the calcium absorption and protein digestion, so that reduces the availability of calcium to the bone tissues, and this makes the bones more brittle. Your histamine blockers decrease your acid. They're used for longer acting and may have fewer side effects with less frequent dosing. They can promote healing of inflamed tissue. A Pepcid and Zantac are two of those. A diagnosis for GERD is an EGD. It allows the physician to see the esophagus and look for abnormalities. It uses moderate sedation, and the physician can also take a biopsy to see if Barrett's esophagus is present. It can also take biopsies to see if H. pylori is present, which we will discuss a little later. And then I also put on here lifestyle changes. There's a chart on page 113 that goes over lifestyle changes such as, caffeine beverages, coffee, chocolate. Smoking puts the patient at a risk, high levels of estrogen and progesterone. And one thing that I had not thought about prior to doing your video is NG tube placement, because anything over 5 days helps to keep that cardiac sphincter valve open, so therefore it puts the patient at more risk for GERD. We're going to switch gears a little bit and talk about hiatal hernias. Hiatal hernias increase the risk for GERD because of intra-abdominal pressure. H. pylori can also contribute to reflux as well. It causes gastritis, and also the stomach doesn't allow the gastric acids to empty as well, and this increases the acid exposure to the esophagus. So I'm going to go ahead and go to the next picture real quick. Actually, I think I accidentally deleted the picture that I wanted to show you, but if you get your book out and look on page 1114, it shows you the different types of hiatal hernias. The sliding hiatal hernia is the most common, and you have a portion of the fundus of the stomach. It slides upward into the esophageal hiatus into the chest. This is from a weakening in the diaphragm. The hernia moves freely. It slides in and out of the chest. The primary symptoms are associated with reflux, so you can have a lot of the symptoms that you have as with reflux. One thing is you want to check your lung sounds, because lung problems, similar to things like asthma, pneumonia, can be triggered by aspiration. So you know that we want to be listening for crackles, and especially at night. The symptoms worsen at night when the patient is in a supine position. The next one is the paraesophageal or the rolling hiatal hernia. Your gastroesophageal junction, it remains in its normal location, okay? But as you look at the picture, you have a fundal part that kind of rolls to the side, and it rolls into the chest beside the esophagus. This herniated part can be small or large. And one thing to remember is reflux is not normally present in the rolling hiatal hernia, but the risk for volvulus, which is a twisting of any type of a structure, is greater. Strangulation is also high, and when anything is strangulated, remember that it puts a patient more at risk for bleeding. Patients are also at a higher risk for iron deficiency because you have a really slow bleeding, and it causes the gastric mucosa to become engorged and just ooze out the blood. Patients can have a feeling of fullness after eating or have some shortness of breath, and they can experience, again, chest pain that mimics angina. A barium swallow is the best diagnostic test for hiatal hernia. Also, rolling hernias are clearly visible with the barium swallow. The sliding hernias can be observed when the patient changes position, and they will have the patient change position with the barium swallow. And sliding hernias can also be seen with an EGD. These can be managed medically or surgically. They try medically first. It's based on the severity of symptoms and the risk for complications. Sliding hernias are most often treated medically, whereas the rolling, because of the risk of strangulation, they treat surgically. And I'll go over more of the surgical and the community resources in class. With GERD, one of the main procedures they do is called a Nissen fundoplication. I've had one, so I can go over that a little more with you in class, and they can also use Nissen's for for hiatal hernia repairs. So that is the end of this video. Again, please make sure you look at your case studies, and thank you.